So welcome everybody. Welcome to our show today. This is Casual Conversations with Brain Injury Professionals, which originally came from the Brain Injury Professional magazine, Women versus Brain Injury, and we've sort of expanded. You keep coming to our show and we keep having shows. So thank you all for joining me today. And I want to thank NABIS and IBIA for hosting this on their Zoom platform. And I'm very much looking forward to the upcoming event, which will be July 28th through 30th, the IBIA Virtual World Congress. And registration, abstracts have already been submitted and registration is out there. So make sure we put up in the link in the chat for people that are interested. And the rates are very great for CME credits. So if you need CME credits or just want to come to a fabulous virtual conference, please sign up. So I want to welcome Yelena to the show today. And a lot of the shows that I've done are people that I've met at conferences and hung out in the bar and had a chance to talk to. And one of the first things I said when we had our call this morning was, you're one of those people that I haven't had a chance to have lunch with or hang out at a conference. So it's great to have you on our call today.
Thank you for having me.
You have had a stellar career, and as the time that I've known you, small children were coming along. I remember when you were a new mom on maternity leave when you presented at the U.S. Congress at the congressional hearing.
Yes, yes, running from Capitol building back outside to the car to nurse. I remember. That was 5 years ago now.
Yeah, the sacrifice that you've done to do both. What I wanted to talk about to start is, how did you get into brain injury? And what I've found in these conferences, in these talks, is that people don't end up here just by chance. There's always some connection to a family or friends. So would you share in your experience how you became a part of brain injury?
Sure. So when I was 14 years old, I had a grandfather who I was very close with. He was 71 at the time, and he was a victim of a random assault by a severely mentally ill neighbor who caused a very, very severe brain injury, intercerebral hemorrhaging, hospitalized for over a year. And he ended up coming to live with us. And we became his caregivers. Because I was very close with him, I also spent pretty much an entire year in the hospital with him as much as I could to see his recovery. And so that really, seeing the changes he went through and seeing the modifications and changes and the impact it had on our entire family as new caregivers, really raised my interest in traumatic brain injury. Beyond that, he was also older when it happened, and he lived for another 14 years with this brain injury and went through an aging process. So that really struck my interest in both brain injury, but also aging and aging with a compromised brain. So when I went to graduate school, I really structured my experiences based on that.
And what decade was this, the beginning and the 15 years that he was living with you?
You asking me to age myself, Catherine?
No, I'm just
I'm kidding.
What I wanted to
so
ask,
his injury was in 1994.
And what was the response from the brain injury community to the family that suddenly had taken on this role of caregiver?
There was very little. And that was, having gone through that experience and seeing the way things are now, I really think it would have been different had this happened today, because we received very little education, close to none at that point, about what to expect and what types of things we can do to really provide the best care for him.
So that was at the current moment. You weren't getting support in the current moment about what to do.
Yeah, so we were winning it. and not really understanding where the memory problems and the major personality changes were coming from, or what we could really do about it.
And then how about as he aged from 75 to the next 15 years, how the brain injury changed over that time frame?
Well, I would say that it most certainly diverted him from a normal aging process, both cognitively and medically. I think from what we understand today is brain injury does does trigger certain comorbidities. So he developed a lot of medical conditions without any premorbid conditions, so things like end-stage renal disease, requiring dialysis pretty much right out of the hospital, and cognitively, he ultimately developed dementia, and a lot of vascular conditions, which he has no family history for, and really was a very, very healthy person with a very healthy lifestyle to begin with. So it did compromise, I think, his aging, both medically and cognitively.
And how did the medical community help you or prepare you for this transitional time as he aged with a brain injury?
I think that's a tricky thing to gauge because as time went on, I also educated myself. So I think and I was also going through my training. So I think I knew how to seek resources better at that point. And I became a better advocate. So I think in our case, ultimately, because of my position and my training, we were able to obtain better care as time went on, and really make the connections between the brain injury and other difficulties he was experiencing. But I don't think it was readily available or freely offered at the time. It was certainly something we had to advocate for and seek out.
Then tell us a little bit about your career path from your education.
Okay. So I did my training at Yeshiva University, Ferkauf Graduate School, which is connected to Albert Einstein College of Medicine. So a lot of opportunities to really become involved in aging because they have the Einstein aging study. So I really tailored my experiences to I'm a clinical neuropsychologist by trade, and I tailored my training experiences to really specialize in aging in general, but also in brain injury and rehabilitation. So my early experiences were really getting a lot of geriatrics and cognitive aging education and training. And then as I started internship and my fellowship, I tailored those experiences to be more specific to traumatic brain injury and rehabilitation, both clinically and research.
Did you find that there was a lot of other people that were interested in the same piece of the brain injury puzzle? Yes, and I think especially with today's zeitgeist of understanding that brain injury compromises aging and that it is a chronic medical condition, there has been more interest. And one of my cohorts on fellowship was Kristen Dams-O'Connor, who is brilliant and is also doing a lot of her research in that area right now. Small dog barking. I actually spent about an hour on the phone about a half an hour ago with Kristen talking about this exact topic and how important it is and the importance of longitudinal studies to look at these pieces. And I think we focus so often on, which is important, on youth and youth sports. And I think too often the aging process and older people are left out of the conversation.
Exactly.
So tell us a little bit about the research that you and the clinical work that you've been doing currently.
Okay, so as far as my research, I have two main interests, as you probably have gauged. One is aging and one is sex and gender issues. So some of the research I've done that I'm really passionate about is specifically looking at reproductive differences and the impact of traumatic brain injury on sex and family planning. So I've done some research in that area. And the research that we're focusing on currently is really more related to clinical translation. So we're part of a model systems program. We're one of the 16 traumatic brain injury model system centers. And what we're currently studying activity limitations and looking at tracking those across the brain injury continuum, and really with the hope of using that information to develop better treatment approaches that are more individualized and more focused on ways to translate better to community participation and meaningful engagement. You're on mute, Katherine.
Thank you. See, my co-host. Those are both, I mean, each one of those areas is so fascinating. Talking about the sex and gender piece, which is what you spoke at the congressional hearing on, which I think was the first congressional hearing on women and brain injury ever. And I know Angela Colantano's work, and that you have together run the Women and Girls Task Force at ACRM, which I think is really the first time, 2010, I think, when you formed that group.
Yeah.
What are some of the pieces with the women long-term brain injury that you think that we should be educating female patients about?
Well, I think endocrine functioning and sexual functioning is certainly key. Because unfortunately, there's not a lot of information out there right now, right? So one of the things that our task force is really focused on is advocating around the fact that we need more research focusing on women, and we need to understand what the sex differences are and what the unique needs of women are. But what we do know from the small amount of information that's available is that women tend to experience a lot of changes with regard to reproductive health, which can impact family planning, can impact relationships. They experience a lot of issues in terms of, menstrual functioning, in terms of painful intercourse, which doesn't get addressed a lot, I think, both clinically and in the research. We know very little about what happens when women with traumatic brain injuries experience the hormonal withdrawal that comes with menopause. And that really needs a lot more research, because, there's some ideas and speculation that just in a uninjured brain, that type of hormonal withdrawal can lead to some cognitive changes. So we have no idea what the impact would be on somebody who's already dealing with a chronic condition like a brain injury. And then the relationship issues are also extremely important. And I think we need focus on both in research and clinically. I used to, when I was doing my fellowship at Mount Sinai, I used to run a women's support group for women with brain injuries. And one of the things that very commonly came up was the deterioration of relationships that women tended to experience. Divorce rates, we know, are much higher in women than in men. And they used to joke around and say, women stay and men run, referring to the fact that if women become caregivers, when women have to take on the caregiving role, they're more likely to really remain in that role, whereas men have a more difficult time, and women with brain injuries are more likely to end up without the support system that they had in place prior to. But there's not a lot of, and this is all anecdotal, right? There's not a lot of information out there. So that's something that should be explored and addressed. And then the idea of what is considered important in rehabilitation. Women traditional female roles are different. Even though I know our world is changing and it's not a universal rule, but more so than not, women are homemakers, in addition, most times, to also having a professional career. They're more likely to raise children, take care of the household, And those types of roles are not always given equal value when it comes to things like vocational rehabilitation, community reintegration programs. And that is also something that really should be focused on more.
I think COVID has really put the focus on how many women are in the gig economy and have 3 part-time jobs plus caregiving roles on both sides, either of parents or of children, and then or work full-time jobs, and then on either end have those caregiving roles, and with COVID at the same time. So I think what were they calling the economic impact to women through COVID, and also the psychological of the caregiving roles that have just increased. And I think I've seen that when I've talked to the VA and I've talked to other programs about setting up rehab programs for women, where men can generally get away for 3 weeks and come to a program. Women can't extract themselves from their lives, from kids, pets, parents, people that they care from, and come for a 3-week program. They can do a month, and then a weekend, 6 weeks, or a couple of months, and then another weekend. But even with a brain injury, there are so many tasks that women are already doing that they can't be available for a 3-week rehab program.
Right. And you bring up COVID, and another big focus and concern right now is intimate partner violence, right? So, and that's another area I've done some work in with women in TBI, is developing a framework for really trying to screen for this. So we know that women are more likely than men to be victims of intimate partner violence. And we also know that having a TBI or any sort of disability increases the chances of victimization. But I think especially with COVID now, the environment is primed to keep people at closer contact with potential aggressors without any opportunity to escape. I think it's getting better with things opening up, but we really don't know what's been happening over the last year. And that is a major concern right now. And there's not really great ways to screen for this. I think more and more women's shelters are looking to identify, are becoming more aware of the potential of traumatic brain injuries resulting from intimate partner violence. And they're certainly doing a better job screening and setting women up with appropriate services for that, instead of just locking them into a psychiatric diagnosis in a psychiatric system. But we don't know the reverse. We don't know how many women who are not presenting and exposing the fact that they've been victims of intimate partner violence could be out there also, with concussions. So, and I don't think there's an easy answer for this, but that's another thing. Actually, Kristen and I have been discussing that a lot, because we developed a framework at JFK, and they have an instrument at Mount Sinai that they've developed, and we're looking for ways where we can integrate those and enhance our way of identifying women who might be silently suffering from both.
And I've often wondered whether the increased rate of dementia in women to men, that whether domestic violence and violence played a role in that, and that along with biological differences, were there differences from the experience of violence that brought early onset dementia. So I'm really hoping that we get in the next 5 to 10 years some more data on that.
Yeah.
As hard as it is to get, I don't think that until recently people have tried. So Eve Valera's spoken on here, Kathy Monahan. There's just such a great group of people out there, and a huge fan of Kristen's. People, women, men coming together to do this work.
Yeah.
And I think, in the same way that sports research kind of exploded in the last 10 years, I'm hoping that domestic violence and interpersonal violence will, we'll look back 10 years from now going, we've just lived through, a period where we really started to flesh out some of these issues.
Yeah, I agree. I think it's more complicated again, because I think we're doing a better job studying the women who have identified that they have been exposed to intimate partner violence, but I think those represent a different cohort than women who remain in the situation and aren't able to escape.
Yeah, I think it's hard when from the perspective of, well, we just have to empower them to leave or give them the skill set. And you're talking about women that have experienced brain injury, and and that alone is such a huge barrier to overcome. And in our support groups, so many of the women in our support groups, from whatever reason they became a person with lived experience of brain injury, are alone. They're divorced, friends have pulled away, families have pulled away, and well, you're milking this for all it's worth, or there's obviously a psychological issue because, cousin Ronnie got over his concussion in 3 weeks, and why are you still having symptoms 2 years later? And I just feel that so often women get isolated. That was one of the purposes of our support group, to bring women together, to create peer support, and to show the commonality that of where women who have now also disengaged from the medical community and aren't getting help. If new rehab therapies come out, they're not even in the system anymore, or can't afford to be, to benefit from those advances.
Yeah.
So what, in the last 10 minutes, told you to go fast, what would you like to see moving forward? Like, what, if money was no object, what is the direction that, what would you like to see happen?
I would like to eradicate the world of brain injuries. Right. I think there's too much to list, right? I think if I had to prioritize the topic that we're discussing now, the idea of intimate partner violence would probably be priority. Intimate partner violence, interpersonal violence, being able to identify and really provide services that patients need. I would want to make sure that all patients with brain injuries had the funding necessary to receive the services. And I would really hope to be able, and I know a lot of work is being done in this area, but to put the money not only to put traumatic brain injury on the map as a chronic medical condition, with the understanding and acceptance that this is something that most people have to deal with for the rest of their lives, and that their medical health and their cognitive health and their psychological health is likely going to be different from people without a brain injury, but also to use that money to provide resources to make sure that they're able to access the care that they need. What you just mentioned about women not being able to access care later on, I think that's very true for people who have identified injuries and problems, and develop new problems later down the line, 10, 15, 20 years, and need to get back into the system, need to get, another course of cognitive rehabilitation, or have developed medical comorbidities as a result of their traumatic brain injury, like compromised immune function, or like my grandfather, end-stage renal disease, to make sure that they're able to access the brain injury rehabilitation system again without any difficulty, to enhance their quality of life and well-being as they're living with this lifelong condition.
And noticing some things going back in the chat. Judy asked, you say that most people with brain injury have to deal with it for the rest of their lives. I thought it was like 20%. I think that we can characterize mild TBI, which for some people isn't mild at all, and does have, I think that's where the 20% comes from. It's the 20% of mild TBI will have symptoms that will go on for months, years, and then moderate and severe TBI. These tracks, these groupings used to be kept very far apart. And I think it's healthier now that they're being included together, because I think there are people with moderate TBI, that with mild TBI that have, severe symptoms. And then there's people with severe TBI that may not develop the same symptoms, because every brain is different. Is there any way that you'd like to classify those different groupings and how we're talking about future issues?
No, I think you've done a good job. I think milds are certainly a bit of a different classification. And yes, we expect most people with mild traumatic brain injury to make a full recovery, but there is that about 15 to 20% that go on to experience lifelong chronic issues, and they just do not recover and we don't really understand very well why that is. But moderate severe, which is mainly what we tend to work with, clinically and also in our research programs, though most of those patients do tend to experience lifelong issues. And it's not just cognitive problems. Fatigue, I think, is a major factor for 80 to 100% of patients who go on to chronic stages. And there are other medical and cognitive problems that continue and then potentially get worse as it coincides with aging.
And I was just thinking that the reason also to go back and re-engage with the medical community, I think the good news is if it is an endocrine issue, which happens in men and women. I know that the military protocol is 1 year after a moderate to severe TBI to do a complete panel on the men, to see where their hormones and all the endocrine system has kind of ended up after a period of time, because there's such fluctuation, but that there are treatments for endocrine issues. At some of these subsequent comorbidities, there are actually treatments and therapies and things to improve the quality of life.
Yes.
So I think too often people said it's a brain injury, there's no treatment, I'm not going to re-engage. Or they've engaged and either run into a brick wall, either because of systemic racism or financial issues, or just a mismatch of patient-doctor, interaction. And then that represents all clinicians to them. And too often, people haven't been to a doctor 2 or 3 years. So I always try to encourage people to go re-engage. And if it isn't this particular, if you have a bad experience, please try again. There are so many people I know out there that are so devoted and amazing clinicians, and you just have to keep trying. So that's kind of my pitch to people with brain injury is re-engage. Science changes.
And I think in addition to that, and I absolutely agree with that, sometimes there's absolutely needs to be a good match between a clinician and a patient. But in addition to that, I think what's improving in our field now is also that more and more, there's more awareness on brain injury in general, and more clinicians are specializing, or at least becoming more educated in brain injury and the potential connections between brain injury and other medical conditions, which in the past we were not aware of. So like the endocrine issues, absolutely, and there are more and more neuroendocrinologists who specifically specialize in brain injury and can address these endocrine issues in both men and women. Work on family planning and reproductive medicine. So it's really a matter. I am very hopeful that we're going to grow in that area, and that in the next 10 years, there's going to be much greater awareness and more people specializing and having a better understanding about brain injury.
And no, I agree. And I think as everybody from dentists to eye doctors, ophthalmologists, all the different people, all the different professions that help us try to maintain our health, start to understand what questions to ask, and we can have more people screening for it. You know, and you know, when was the last time that you had a doctor ask if anybody has hit you, choked you, or if you've been unconscious due to a blow, or some question to open up the conversation? And then I also think that people just have to understand that in basic medical training, doctors may get 6 hours on traumatic brain injury. And if it wasn't part of your rotation, that not everybody out there in the medical community has a current understanding of brain injury, or even more than a basic understanding whenever they were in what particular training that they had.
But I think, again, with the movements that are happening in the field now of understanding and appreciating as a chronic medical condition, I mean, there are great people behind this, like John Corrigan and Flora Hammond. Flora actually just got a big grant where all 16 model system centers are participating, specifically looking at these issues and looking at the chronicity of various aspects of traumatic brain injury and developing better care systems for it. So I do feel confident and positive about this.
I was just reading the chat. Kathleen Monahan had to go and said, thank you so much for all your hard work. And I could listen to you all day. Sorry, I have to go. Again, I could love talking to you. We talked an hour this morning. There's just so much that you have to offer in this space from age perspective and the sex and gender issues. I did want to open it up for questions as we are. Let me move my view.
I'm actually looking at a question that Kara asked, looks like a while back and we ignored it, sorry, about could you please share your knowledge or any research about the impact of TBI on women during pregnancy? You know, I am not aware of any studies specifically looking at the impact of TBI during pregnancy. I think the closest information that is out there is the impact of TBI on fertility, and that the research there basically suggests that fertility can be compromised as a result of traumatic brain injury, needing additional interventions. And anecdotally, a lot of my patients or people who've attended talks where I've discussed these issues have talked about difficulty getting pregnant after having a traumatic brain injury and just needing specialized services. The other research of traumatic brain injury during pregnancy, I think, really comes from more of the hormone studies. There's been a big move looking at, you know, the protective factors of estrogen and progesterone. And what that really implies or shows is that pregnancy actually has neuroprotective factors because of the high levels of progesterone that are produced during pregnancy. Women are less susceptible to the same amount of damage that they would have experienced from the same type of injury had they not been pregnant. But as far as TBI having a specific impact on pregnancy, I have not seen any research about that.
Or any neurological changes that could possibly transfer to or affect like the development of the baby or anything, you know, that if you're having hormonal changes or interruptions or problems like as the mother, then can that lead to any sort of just your, I guess, I don't know, just translation, not translation, but transfer of any sort of, you know, hormones or anything like that, you know, to the embryo.
Yeah, I have not seen anything like that. My understanding is the hormones that, I mean, I know it's very little research, but what it shows is the very little hormone, the amount of hormones that are produced during pregnancy are actually protecting you and the baby.
Somebody also wrote in a comment after my question that she said, she said that her daughter is 33, had a TBI at age 14, that recent hormonal changes seriously impacted her pregnancy, which she was afraid of, and she chose to abort. Yeah. And now she is even more mentally discomforted and distorted in her thinking, and that her husband's leaving her more in the lurch. So I didn't, Ginny, I didn't know if you wanted to speak, or I was just reading the question that you put in the box. So I guess just I'm following to that, just so I guess that's you're saying the same thing, that there's
cry to see what she's going through. And I wish that she won't even let us help her reach out for help. Sorry.
I do hope that in the future that we, have more of an idea of, what to recommend to women of all ages, so that, if they're young people, I know there are issues. I know when my son was warned with his TBI, that he would have a very short runway with drugs and alcohol, and that his teenage years could not be the same as they were for somebody that had not had the brain injury that he had. I think that there are, certain things that I wish we knew at different ages when someone has not had children, when somebody has small children. And I have seen women in our support group struggle that have toddlers and a brain injury, and how to parent with a brain injury on through to, as we were mentioning, menopause, post-menopause, and how all those factors fit in. So we just don't have all the pieces yet. Luckily, we have some amazing, many women and men, John Corrigan, Kristen Dams O'Connor, Yelena. There's a great group of people working on this now. And we were talking about a really great group of men, women, people of color, diversity. There's more diverse people coming up in the medical community now, which I think will have more diverse interests, diverse research. And I think I am optimistic about where we're going to be in 10 years from now.
I just think as a woman, when you're going to go through, just because that I've seen with myself and peers, like going through everything with fertility treatment and in reproductive treatment now, and people getting pregnant later, which is helpful for people who may have had an interruption due to traumatic brain injury or other trauma. The question of what will the impact be on me? Will it be different? The neurological impact of pregnancy there's on hormones and everything like that. And their answer is, we don't know. Maybe talk to your neurologist or talk to whoever. There's just such a lack of understanding. And you would think, because of hormones, especially, that's so tied to your neurological system, so it's just, you don't want any surprises, but you kind of have to, without the knowledge, go into it that way. And you can't really prepare yourself as well, psychiatric as well. So that's just something that I'm, hope we're getting some more attention.
Yeah. And, again, like, as everybody's pointing out, we don't have enough information, but just the possibility that hormone levels might be different as women with traumatic brain injury progress through pregnancy may be something to alert our doctors about, right? Because I remember when I was pregnant, they stopped measuring my hormones once they were high enough. And that was the first trimester, and then you're done. So maybe for women who are in this potential risk group, they need monitoring throughout their pregnancy, right? Because there are hormone replacement medications. There are ways there have to be ways to address some of this, same as they have for women going through menopause. But I think there's just probably not enough monitoring and understanding that this is a possibility. And if we go into this by letting our OBs or reproductive professionals know that, my hormone functioning might be different because I've had a TBI, they might take a different approach that might be more conducive and more protective of the pregnancy.
Thank you.
I wanted to give Judy a chance to speak, and Yelena does have a 3 o'clock call. So
Katherine asked me to do this not even a week ago. So I cleared this time slot, and then she said, log in a half an hour before. Let's chat a half an hour after. And I said, no.
So we'll do sort of a speed round. I think we just lost.
No, you didn't lose me. I'm here.
Oh, there you are. Hi, you dropped.
I took my
raised her hand, so she got
my hand down. Yeah, sorry. Thank you very much for I want to change the topic. Is that all right, to get into aging? Yes. I had what they called a mild TBI 5 years ago. And what I find is that I managed to get better after 4 years, okay? I felt a lot better, got my energy back, got treatment at a clinic that knew what they were doing. But what I find is every time I get sick or injured, the concussion symptoms come back. And I'm worried about dementia because I have no dementia in my family, but I've been noticing lately, I had a fall and I broke a couple of ribs. I didn't hit my head, but I'm noticing the kind of working memory, you know, loss of working memory. Like I forget 2 seconds later what I just decided to do, that kind of working memory. And I just wonder, is that concussion? Should I get checked for dementia, even though there's no dementia in my family? I understand if you get it early, you can deal with it better. So I'm very, you know, I was 70 when I had the brain injury. It's 5 years ago. So, but I'm a very energetic person for my age. No. So I'm wondering about that.
Don't look your age either. What's your secret?
What's my secret? Activism. Yeah, activism is my secret. Yeah.
You know, Judy, that's a good question. And that's another question we don't quite have the answer for right now. And there's research brewing in the background and we're studying these issues, but we don't know, you know, and as Katherine pointed out, just because an injury is mild doesn't make it any less impactful potentially as any other type of injury severity. So some of the things that you're describing, you know, forgetting why you walk into a room and a little, that could also be normal aging. Mm-hmm. So, and especially for people who are very high functioning, very active to begin with, even the smallest deviation from the way they're used to functioning can be alarming. So I think the best, what are you at risk for dementia? It's really difficult to say. The fact that you've made such a good recovery and you felt like you were back to baseline, I think is a good sign. Could there be some sort of, you know, underlying neurological compromise? It's impossible to really know, right? And is that gonna accelerate the aging process? We really don't know. The best way to stay on top of it really, I think, is to have routine neuropsychological evaluation. So I would definitely get a baseline as soon as possible. And I'm sure you may have had one.
I have one, and I have to get another one for my lawsuit. So
okay. Yeah. So yeah, you know, every couple of years, get an evaluation. You know, there's also the base rates with just normal aging and conversion rates to cognitive impairment and dementia that have nothing to do with traumatic brain injury. So it's not clear to what extent or whether that accelerates an injury accelerates things. So I always recommend for people to get regular evaluations and see if anything deviates from what we would expect from normal aging. If you're starting to see an accelerated process, then yes, you want to nip it in the bud sooner rather than later. But from what you're describing right now, those symptoms, that sounds like normal aging that I hear 50-year-old patients say. So the fact that you're just experiencing this now, again.
No, I've experienced it before, but not quite this. Like I forget people's names and stuff like that, but this is different. This is like, you know, I'll find a charger in another place and not remember having put it there, okay. Right? And not remember that it's broken. So it's more serious than just.
Okay.
So and I haven't had that before. So, but I'm going to get it checked anyway. So that's all I need to do, right?
Yeah. Well, yeah, and you know, and also I think it's important to keep in mind there are other circumstances that are more psychosocial in nature that can also, you know, take up mental energy and be distractors. So there's more and more research out there that for people who are going through litigation, that can also have a psychological impact that can compromise cognitive function. So I think being aware of, you know, the fact that our emotions can, yes, emotional dysregulation could be triggered by a brain injury, but also just reactive emotional situations can also, they consume mental energy, right? The mental energy that we would otherwise devote to things like paying attention and remembering that we broke our charger or where we put it. So the more we have on our minds, the less energy we have to focus on everyday things.
Okay, thank you very much.
And I personally was experiencing that because my neuropsych had happened when I was 30. They also diagnosed I was ADHD. which my son had, who had never had a brain injury. So all of a sudden, everything that I was putting on my brain injury turned out, I had to sort out what was ADHD and what was my brain injury. And then 10 years later, I was really struggling. The more I struggled, the more anxious. So I went back and got kind of like a tune-up, they called it. It wasn't as expensive and it wasn't as many hours. And he didn't really write a full report. And I said to him, what I can say, he said, well, there's a little bit of decline. And I go, what do you think? He goes, well, when I measure you to your 50-year-old peers, as opposed to your 40-year-old peers, you're in the ballpark. And I'm like, oh, okay. I think we're the first generation to forget the keys to where we put the keys to the car. And it isn't just like, oh, I'm getting old. I mean, I think we have a lot more pressure on ourselves because science has pulled out more sinister, aging process has a sinister element to it in some of the ways that we look at dementia now, as opposed to maybe an expectation that cognitively we're going to decline a little bit over time in normal aging. So I think it's important, and getting that assessment just took so much stress off me, and I was less anxious about it. So how about one or two more questions?
Hillary, did you want to read your question, or did you want me to go ahead and read it out loud? I can go ahead. She wrote that she'd been reading a lot of research and articles about the race to get a quick field test for concussions using biomarkers. And do you have any thoughts about this, like when this might actually be available?
That is a little bit outside of my area of expertise.
And generally, those are more about on the field sports. I mean, what they're looking for is they're looking for biomarkers on the field that they can do a prick test or some sort of sweat test to then know to pull athletes out. So
yeah, I'm not really, I'm not very involved in sports concussions at all. I feel like that's a whole different world from where I function. And I know back when I was doing training, they were trying to develop tests using eye trackers to see if there was any brain injury. But I'm not really aware of any viable biomarkers at this point that are validated and trustworthy.
Are you knowledgeable about diffusion tensor imaging?
Yes. Oh,
go ahead.
Sorry.
Was there a question about diffusion tensor imaging?
Yes, there was.
Okay.
That she said, are you aware of research that the underlying cause of TBI has a physical component being uncovered through DTI, and that structural connectivity, white matter damage, as revealed in DTI, reveals that some mild TBI is actually more severe and a better measure of the likelihood of persistent post-concussion syndrome as a long-term issue?
Right. So yes, with the advent of DTI, we've been seeing that, you know, the disconnection syndrome and the compromise on white matter integrity is certainly very extensive in mild traumatic brain injuries. You know, unfortunately, it's not a clinical tool right now, and it's only research based. And one of the, you know, criticisms of DTI is that we don't really know how to interpret what we're measuring. So is more connectivity in certain areas better? Is it worse? Is the diffusion, do we want more diffusion? Do we want less diffusion? It's sort of very experimental in nature. Despite those arguments, I do believe that the disconnection syndrome is what probably contributes to a lot of the post-concussive difficulties that our patients experience. And I do hope that we do get better at interpreting the clinical data from DTI, because I think ultimately it's going to validate a lot of what patients with mild TBIs complain about that often get dismissed or misattributed or reattributed to other etiologies. I mean, there's the whole big controversy about psychogenic versus neurogenic. And I think what we see sometimes with DTI results is that it corresponds very well to the deficits we see in neuropsychological testing when they are detectable. But I think in general, mild TBI is there's still so much controversy there that we just need more research and better clinical tools that are, a lot of which are still experimental in nature.
Well, then that can translate to more treatment as well. whether it's therapeutic or pharmaceuticals.
And I personally feel very strongly that we need to just keep pushing the term post-concussion syndrome out of our lexicon and focus on prolonged or persistent concussion symptoms. And that too many people are caught in this syndrome mindset that I got a syndrome, no one can help me, I can't, there's no treatment for me. And again, it's about re-engaging with the medical community. Mm-hmm. And if you've had a bad experience, just keep trying. I mean, there's so many, there's so many amazing people on this call. Marilyn Spivak's here too. I saw her.
Hi, Marilyn. Marilyn is the driving force behind our task force and so much of what we're doing at ACRM.
Marilyn, did you want to unmic and say hi? Sometimes she's driving.
Okay.
But yeah, so all important, so excited to have had this chance to talk to you today and to get to know you a little better and see no kids or dogs went by on your end and I had the barking dogs on my end.
Well, that's why I moved to the basement, but I was more concerned about, there was some screaming, but I hope you didn't hear it. I was more concerned about like a toilet flushing and everything coming down the pipes.
I just see one question put on by Isabella. Do we just have a minute just to read that?
Okay.
You mind? Yelena, is that okay?
That's fine, yeah.
She said that she had a DTI, but the results were normal, but she does have persistent PCS symptoms. How can her symptoms be explained? And is there other testing? And would a SPECS brain scan or FNCI be helpful after a normal DTI?
So, and I think it goes back to the idea of us not really knowing what normal is with DTI or how to interpret it, right? So because there are no reference points right now. So it's an experimental measure. It's not clinical in nature. So I'm not sure what normal really means. And just because one neuroradiologist is saying that this compares to what I've seen in other people, that may not be normal for everybody. So, I mean, mild traumatic brain injuries usually don't show up on imaging. They're most likely disconnection syndrome. There's a compromise between, connectivity between brain networks that doesn't always show up even on testing. What we know is that it makes it more difficult to do regular tasks. We need more mental effort. So I view it as a depletion of brain resources and brain energy that's not always detectable, especially in higher functioning individuals, because they're still able to function, right? But they know that something feels different. And the field really needs to develop better ways to assess that. I think the tools we have now just don't always pick up. And if somebody tells me that a DTI is normal, I'm not sure what that really means. So I would not read into that too much.
And I've personally had every scan out there. You name a scan, functional MRI. I mean, I have thrown myself into every research project that's available. And I feel great that I've contributed to research, but actually what they were able to tell me from my scans, despite the fact I have access to pretty much every scan that's out there, including a functional MRI, there wasn't really that, the data was thanks for helping with research. And it's really important. I mean, Pink Concussions has the Pink Brain Pledge. And, if everybody signed up to be a part of these with our study with Mount Sinai, you can go in and get an MRI and get blood work and all of this medical, all this medical data is collected no cost to you for part of the research. So we're still at the part where please be a part of the research, please be engaged with the team, and to be continued for the results to come back. But I do find it exciting to be a part of the research. And I'm so happy we're led by researchers like you, Yelena.
Thank you so much for being so welcoming. I really enjoyed this talk and I'm impressed by the turnout.
Yeah, I told you it's a really great group of people and they keep coming back. And I have promised, I know there's some more questions, but I promised, since I asked Yelena last minute, that I would let her off and let her breathe and come out of the basement for her next call.
I'm stuck here now. That's it.
Yeah,
but, as a last just word,
yeah, definitely.
We're talking about concussion and post-concussion syndrome, and I also have, I think I share similar views to you that I prefer to call it's a traumatic brain injury, right? So mild, moderate, severe, a brain injury is a brain injury. It's often difficult to predict what the outcomes, especially the long-term consequences and, the chronic factors are going to look like. So I think immediately classifying it, as a concussion or a mild injury, we need that to understand, for medical reasons, we need that to understand the amount of impact it had on the brain and help a little bit with, some sort of prognostication. But ultimately, they're all brain injuries. And we never know what the impact on every specific individual is going to be. So I really stay away from using the term concussion. And I encourage my residents and fellows to do the same. It's a TBI. And the rest will be determined.
And we've got great people leading the way. So thank you for your time today. Thank your husband for watching the kids. Thank the dog.
Yes, for staying quiet, everyone.
Yeah, and it's great to spend this time with you today and everybody else. We have no more breaks coming up. We have every week, we've got a fantastic guest leading up till July when we'll have the conference. I don't know if it got in the link, but I'll make sure it's in the next email, the virtual IBIA Brain Injury Congress, 3 days of pink concussions tracks. And you can also, if you get tired of us, you can go to another track and then come back. But mark your calendars for July 28th, 29th, and 30th. So thank you, Yelena. And except for the last time I got your name right each time.
Okay, it's okay.
Showing the brain can learn. Thank you all, and everyone stay safe, and we'll see you next week. Bye, everybody.
Thank you, everybody. Bye.
Bye-bye.
Thank you.